Hello, my name is Dr. Jamerson Holloway, and today I want to talk with you about prostate cancer, and specifically, why it places such an uneven burden on black men. Prostate cancer is one of the clearest examples of a health disparity in the United States. Compared to other racial groups, black men are diagnosed more often, at younger ages, and with more aggressive forms of the disease. So why does this gap exist? The answer involves both nature and nurture. On the biological side, black men tend to show higher prostate-specific antigen, or PSA, levels at younger ages, along with greater tumor volume, and they are markedly more likely to develop aggressive metastatic disease. On the environmental side, factors like access to care, screening patterns, and social conditions all shape outcomes. Over the next few minutes, I'll walk you through what's driving this disparity, and, just as importantly, what we can do about it. Before we go further, let's understand the prostate itself, what it is, where it sits, and what it does. The prostate is a small gland found only in men. In a young man, it's about the size of a walnut. It sits just below the bladder and in front of the rectum, with the urethra, the tube that carries urine and semen out of the body, running right through its center. So what does it do? Its job is mainly reproductive. The prostate produces fluid that keeps sperm alive and healthy. That fluid combines with sperm and with fluid from the seminal vesicles, two glands just behind the prostate, to form semen, the milky white fluid released during ejaculation. Muscles in the prostate then push that semen out through the urethra. The prostate grows as men age, often becoming much larger than the original walnut. Because the urethra runs straight through it, that growth is part of why prostate health becomes so important and why it's central to the screening conversation we'll have today. Now that we understand the healthy prostate, let's look at what happens when something goes wrong. According to the American Cancer Society, prostate cancer begins with changes in the DNA of a normal prostate cell. A group of cells inside the prostate mutates and starts to grow out of control. Some of these cancers grow slowly and may never cause harm. Others grow far more aggressively. If the cancer grows enough, it can reach nearby organs or travel to distant parts of the body, often the bones. That spread is called metastasis, and it's what makes the disease most dangerous. Not all prostate cancers are the same. Nearly all of them are adenocarcinomas, which form in the gland cells that make prostate fluid. Rarer types include small cell neuroendocrine carcinoma, other neuroendocrine tumors, transitional cell carcinoma, and sarcomas. These are uncommon, but they tend to behave more aggressively, which is why an accurate diagnosis matters. So why are black men hit so much harder? Prostate cancer is the second leading cause of cancer death among black men. The reasons span both biology and environment, and on this slide we'll focus on biology. At the cellular level, research shows black men have higher activity in inflammatory pathway genes and lower activity in DNA repair genes. That combination can allow mutations to go uncorrected and drive tumors to grow more rapidly. The hereditary risk is striking. Prostate cancer is one of the most inheritable of all cancers, and specific genetic variants differ in frequency between black and white men. The result? Black men face a 1 in 4 lifetime chance of developing prostate cancer compared to 1 in 8 for white men, and they reach that same level of risk about 19 years earlier, near age 66 rather than 85. One barrier to acting on this is fear that genetic testing could affect eligibility for health, life, or travel insurance. But biology is only part of the story. Many of the factors driving this disparity are systemic and behavioral, which means they can be changed. Start with access. Black men are less likely to be screened than white men, and they often wait longer between an abnormal finding and follow-up care. Layered on top is deep, justified mistrust of the medical system, rooted in Tuskegee, the Henrietta Lacks case, and ongoing inequities, which makes communication with providers harder. Socioeconomic barriers matter too. Limited insurance, lower health literacy, and the fact that even at the same disease stage, black men are less likely to receive treatment. Lifestyle plays a role through diets higher in saturated fat and chronic stress, both linked to inflammation. Finally, culture. Stigma tied to masculinity, fear of the rectal exam, and family silence around diagnoses all keep men from getting screened. Only 27% report ever having a PSA test. Let's look at who prostate cancer affects and how heavily. Age is the biggest general risk factor. The disease is rare before 40, rises sharply after 50, and about 6 in 10 cases are found in men over 65. Family history, genetics, and race also raise risk, and other health conditions shape how it's treated. But the racial gap is stark. Compared to white men, black men are about 60% more likely to be diagnosed with prostate cancer and nearly 2.5 times more likely to die from it. They're diagnosed younger, at later stages, and are less likely to survive 5 years. In fact, Black Americans have the highest death rate of any racial or ethnic group for most cancers. Here's the encouraging part. At least 42% of new cancers are potentially preventable. Smoking alone accounts for about 19%, and factors like excess weight, inactivity, alcohol, and poor nutrition account for another 18%. Now, what should men actually watch for? Most prostate symptoms show up in how the body handles urination because the urethra runs straight through the gland. Warning signs include a frequent or sudden urge to urinate, especially at night, a weak urine stream, or trouble starting at all. Some men feel pain or burning while urinating, notice blood in the urine or semen, or experience painful ejaculation. But here's the most important point on this slide. These symptoms do not automatically mean cancer. Benign, non-cancerous conditions, like an enlarged prostate, which is very common with age, can cause the exact same problems. The symptoms alone can't tell the difference. That's exactly why you shouldn't try to diagnose yourself, and why you shouldn't panic either. If you notice any of these changes, the right move is simple: talk to your doctor and get checked. Early evaluation is what turns uncertainty into answers. So how do we catch it early? The main tool is the PSA test. PSA, or prostate-specific antigen, is a protein made only by the prostate and released into the blood. A higher level can signal a problem, and the chance of cancer rises as PSA rises. A simple blood draw makes it the first-line screening test. But PSA is an imperfect science. It can produce false positives and lead to overdiagnosis and overtreatment, so it isn't routinely recommended for every man. For black men, though, the calculation is different. Black men tend to have higher PSA at younger ages, greater tumor volume at diagnosis, and faster-growing disease. That's why experts say black men should strongly consider a baseline PSA test as early as ages 40 to 45, not 50, with annual screening based on that first result and personal risk. Current national guidelines aren't race-based, in part because most screening research was done in white men. Don't wait. Ask your provider about starting early. We've talked about genes and access. Now let's connect the dots to everyday health, because some of the strongest drivers are conditions many men already live with. There's growing evidence that diet, lifestyle, and common comorbidities, obesity, high blood pressure, and diabetes, fuel chronic low-grade inflammation throughout the body. That inflammation appears to influence both how prostate cancer develops and how men survive it. In other words, managing your weight, blood pressure, and blood sugar isn't just good for your heart, it may also lower your cancer risk. This biology helps explain what we see in the numbers. Black men show higher PSA values at the time of diagnosis, carry greater tumor volume, and their cancer tends to grow faster and turn aggressive earlier. Because their PSA profiles differ, screening for black men may need different thresholds to flag concern. The takeaway: controlling these health conditions is one more lever within reach. So when should the screening conversation actually begin? For most men, it starts around 50. But if you're at higher risk, it starts a full decade earlier, at age 40. Who counts as higher risk? 3 groups especially: men of black heritage, men with a father or brother who has had prostate cancer, and men carrying a BRCA1 or BRCA2 genetic mutation. If any of these apply to you, age 40 is the time to talk with your provider. Here's how it works in practice. Black men who choose screening should get a baseline PSA test between ages 40 and 45. From there, the decision to screen annually is individualized. based on that first PSA value, your family history, and your overall health. It's a shared decision between you and your doctor, not a one-size-fits-all rule. And pay attention to the trend, not just the number. If your PSA has been steadily creeping upward over time, your provider may recommend checking it every 6 months. Rising numbers deserve closer watching. Let's ground everything we've discussed in the evidence. The data on this slide tells a consistent story. Black men in the United States are more likely to be diagnosed with prostate cancer, more likely to die from it, and more likely to face it younger and in a more aggressive form than men of other races. The numbers are clear. Prostate cancer incidence is almost 60% higher in black men, and the mortality rate is 2 to 3 times greater than in white men. When you look at incidence by race, both at the age of diagnosis and the age of death, the disparity is unmistakable. Here's the part that should give us hope and direction. In 2023, the American Urological Association issued a strong recommendation. Clinicians should offer PSA screening starting at ages 40 to 45 for men at increased risk, and that explicitly includes black men. This isn't just advocacy, it's now formal evidence-based guidance. The case for screening earlier is settled. The task now is to act on it. Let's look closer at the 2 screening methods and how to talk about them. PSA is a protein made by prostate cells, both normal and cancerous. Most of it stays in semen, but a small amount enters the blood, where we measure it in nanograms per milliliter. As a rough guide, men under 60 should generally be at or below 2.5, and men 60 and older at or below 4.0. The higher the number, the higher the concern. The second method is the digital rectal exam, or DRE, where a doctor feels the prostate for hard or bumpy areas. Now, here's an honest barrier. The DRE carries real cultural stigma for many black men, and some avoid screening entirely because of it. Some even believe wrongly that a PSA test requires a DRE. This is where how we communicate matters most. The PSA test is just a simple blood draw, no different than checking your cholesterol. Framing it that way removes the fear and gets more men screened. So what happens if a screening test comes back abnormal? The good news is that an elevated PSA or a suspicious exam doesn't lead straight to a diagnosis. It leads to a closer look using imaging. The first tool is transrectal ultrasound, or TRUS. It uses sound waves to create black and white images of the prostate. Its main job is to guide a biopsy, helping the doctor see exactly where to take tissue samples so nothing is missed. The second, more advanced tool is multiparametric MRI, or MPMRI. This gives a far more detailed picture than ultrasound. It helps doctors determine how far the cancer has spread, and just as importantly, how aggressive it's likely to be. That information is critical because it shapes whether a cancer needs active treatment or careful monitoring. The key message here is reassurance. These are precise, targeted tools. An abnormal screen is the beginning of getting answers, not a final verdict. Each step brings more clarity, not less. If screening saves lives, why don't more men get screened? Let's start with the barriers men carry themselves. At the top is fear. Many men fear the diagnosis itself, not realizing that early-stage prostate cancer is often curable, not a death sentence. Our messaging has to make that clear. There's also fear of the exam. A lot of men wrongly believe screening requires a rectal exam when the PSA test is simply a blood draw, like checking cholesterol. Then there's stigma. Prostate cancer gets tied to masculinity and sexual function, so a diagnosis can feel like a threat to a man's identity. Shame and embarrassment make many reluctant even to talk about it, much less get tested. Underneath all of this sits medical mistrust, often well-earned. It makes men hesitant to engage, hard to reach, and quick to disengage. And lower health literacy can make it difficult to ask the right questions or voice personal preferences. These are the human barriers we have to meet with empathy. But we can't put all of this on individual men. Many barriers are built into the system around them. Start with the social determinants of health: racism, intergenerational poverty, unstable or substandard housing, limited access to healthy food, neighborhood violence, and exposure to environmental toxins all shape a man's health long before he ever reaches a clinic. These conditions weigh most heavily on black men. Then there's access itself, geographic distance to screening facilities, insurance limitations, and cost. And bias within healthcare settings only deepens the mistrust we just discussed. Finally, communication breaks down in the exam room. Visits are short and crowded with competing health priorities. Shared decision-making often doesn't happen, and the models we use assume that a patient will speak up, which disadvantages those with lower health literacy or greater mistrust. Some black men even report being refused a PSA test or told they don't qualify. When barriers go unaddressed, the consequences are measurable. Black men are more likely to be diagnosed late, at younger ages and later stages, and less likely to receive treatment early, when it works best. The result is stark. Black men are about 3 times more likely to die from prostate cancer. This population is underdiagnosed, undertreated, and underserved by the system around them. To understand why, it helps to use a framework. The social determinants of health provide 5 lenses: economic stability, access to, and quality of education, access to, and quality of healthcare, the neighborhood and built environment, and social and community context. Each one shapes a man's risk and his outcomes. Consider public housing residents, who face significant disadvantages across nearly all 5. That's also why family history and genetic risk should factor into starting PSA testing in the early 40s. The disparity is structural, and so is the solution. Here's something encouraging. Men don't make these decisions alone, and the people closest to them are powerful allies. Research shows that women, often wives and partners, play 3 key roles in black men's prostate cancer decisions. First, the counselor. Women gather and share information, helping a man weigh his screening and treatment options and make sense of what he's hearing. Female family members are often seen as trusted, credible sources. Second, the coordinator. Women schedule the appointments, help navigate a complicated healthcare system, and encourage healthier eating, turning good intentions into action. Third, the confidant. Women offer a safe space, emotional support, and reassurance, easing the anxiety that comes with screening and surveillance. There's even a useful insight here. Partners are often more confident than survivors that a healthy lifestyle prevents recurrence, a belief we can lean into. The takeaway is simple: engage the whole family, not just the patient. So what actually works? We're not without tools. 2 evidence-based approaches stand out for closing these gaps. The first is patient navigation. A navigator is a guide who walks alongside a patient through a confusing healthcare system, helping schedule tests, track results, remove obstacles, and keep care moving. The evidence is striking. Navigation has been shown to eliminate disparities in how quickly men get diagnosed, start treatment, and complete their care plans. It directly attacks the access and follow-up barriers we discussed earlier. The second is cultural humility. This isn't about mastering another culture. It's a posture of curiosity and self-reflection. It means recognizing that a patient's cultural perspective is just as valid as our own, and honestly examining how power and systemic bias shape the clinical encounter. When we honor a man's values and lived experience, we shift the power dynamic, and he becomes more willing to engage. Respect is an intervention. So what can we do? Let me leave you with a clear path forward. First, knowledge is power. Know your personal risk and your family health history, and bring that to your appointments. Stay informed and ask questions until you have clarity on screening and treatment. Second, embrace shared decision-making. The American Cancer Society is clear. Screening should be a conversation between you and your provider, weighing the benefits, risks, and limits together. No one should decide for you, and you shouldn't decide alone. Third, meet men where they are. For many black men who distrust the system or struggle to communicate with providers, offering screening outside the clinic in trusted community spaces can make all the difference. And community champions matter. Men trust health advice from peers who've lived it more than from professionals. When a respected elder talks openly about screening, younger men listen. Finally, get screened. Start the conversation at 40 to 45 and keep it regular. Underneath every recommendation we've made sits one essential ingredient: trust. For black men, Trust in a provider is one of the most important factors in deciding whether to screen or pursue treatment. Without it, the best guidelines go unused. So how do we build it? It starts with honesty about the past. We cannot ask men to trust a system while ignoring Tuskegee or Henrietta Lacks' story. Trust requires recognition first, acknowledging and validating those injustices openly rather than tiptoeing around them. From there, transparency does the work. Be clear about what prostate cancer and genetic research actually aim to do. Explain proactively how personal data is protected, including the rules around insurance and mortgage disclosure that many men rightly worry about. And here's a powerful truth to share. Greater Black representation in research directly improves outcomes for future generations. Participation isn't just personal, it's a gift to the community. Let me close where we should. Awareness saves lives. That's not a slogan, it's the through line of everything we've covered today. We've seen that Black men face this disease earlier, more often, and more aggressively, but we've also seen that so much of that burden is within our power to change. Early detection genuinely improves outcomes. The cancers we catch early are the ones men survive. Getting there takes two things working together. Community education builds the knowledge, understanding risk, knowing when to start the conversation, replacing fear with facts. And patient navigation turns that knowledge into action, getting men through the door, through the test, and through to care. Knowledge and navigation together don't just change what men know, they change what men do. So take this with you. Talk to the men in your life, start the conversation at 40, and remember, a simple blood test and an honest conversation can save a life. Before we finish, I want to recognize an organization doing this work every day, Zero Prostate Cancer. They are the nation's leading provider of prostate cancer resources, built around a simple promise: zero stigma, zero barriers. Zero's mission lines up with everything we've discussed. They run a patient support helpline, free navigation services, and a mentor program that pairs men with peers who have walked this road. Exactly the kind of trusted, community-based support that reaches Black men best. They've created dedicated resources for Black men, and through their Blitz the Barriers initiative, they're investing in the communities hit hardest by prostate cancer, and they reinforce our central message. When prostate cancer is caught early, the 5-year survival rate is nearly 100%. Early detection truly saves lives. So thank you, Zero, for your steadfast commitment to reducing prostate cancer in Black men. Your work turns awareness into action, and action into lives saved. I also want to thank the American Cancer Society, whose guidance has informed much of what we've discussed today, from how prostate cancer develops, to the symptoms to watch for, to the principle of shared decision-making and screening. For more than a century, the ACS has worked to end cancer for everyone, combining research, advocacy, and direct patient support. Since 1946, they've invested over $5 billion in cancer research, and in 2024 alone, their work touched more than 140 million lives. What stands out for our purpose is their commitment to equity. The Society has delivered millions of cancer screenings in underserved communities and runs programs that remove real barriers: free rides to treatment, free lodging, patient navigation, and a cancer helpline answered around the clock at 1-800-227-2345. So thank you, American Cancer Society, for your enduring commitment to reducing prostate cancer and for ensuring that early detection and support reach every community. If you have any questions, please reach out to your Southern Nevada Black Nurses Association representative.
Hello, I'm Dr. Jamerson Holloway, and as a member of the Southern Nevada Black Nurses Association, it is my honor and privilege to have brought you this presentation on the importance of prostate cancer awareness, screening, and surveillance. Let me leave you with what matters most. Prostate cancer strikes Black men harder, earlier, more often, and more aggressively. But as we've seen, this disparity is not destiny. It's shaped by both biology and the conditions around us, and so much of it is within our power to change. The single most important truth is this: when prostate cancer is caught early, survival is extraordinarily high. Early detection saves lives. For Black men, That means starting the conversation at age 40 to 45, not waiting until age 50. And remembering that the PSA test is simply a blood draw, no different than checking your cholesterol. But knowledge alone isn't enough. We close this gap through trust, through honest conversations about the past, through families and partners who stand beside their men, through community champions who lead by example, and through navigators who walk every step of the journey alongside that patient. So here is my charge to you. Talk to the men in your life. Encourage them to know their risk, to ask questions, and to get screened. Because awareness, paired with action, saves lives. Thank you.
Finally, I want to recognize a partner close to home, the Southern Nevada Black Nurses Association. Right here in Las Vegas, these nurses live out a powerful mission to identify the healthcare needs of Black Americans and drive the change that makes quality care truly accessible. Their founding philosophy, in the words of SNBNA founder Dr. Loran Sams, is that whatever harms Black people anywhere affects us all. That conviction is exactly the spirit behind today's conversation about prostate cancer. SNBNA nurses serve as advocates and change agents. They influence the policies that shape Black health, they conduct and share research on the community's needs, and they recruit and mentor the next generation of Black nurses. In short, they are Black nurses nurturing the community, with community always in mind. So thank you, SNBNA, for your tireless local leadership. The work we've discussed today, closing the prostate cancer gap for Black men, is your work, and we are grateful for it.